So due to glitches on Darshan side, we'll go ahead with the infectious diseases. So I covered catheter-related infections, diarrhea, and tropical infections. So all three are potential questions that can be asked in the exam. So first, coming to catheter-related bloodstream infections, first you need to know the difference between CRBSA and CLABSI. All right. So CRBSI are bloodstream infections where organism identified in peripheral blood is also present in the tip of the catheter or in a blood sample drawn through the catheter. So this is mainly used by the IDSA. So the definition is commonly used in clinical practice and it requires evidence of a catheter involvement with the same organism present in the peripheral blood. So it includes all types of catheters: peripheral venous catheter, peripheral arterial catheter, CVC, PAC, PICC line, long-term CVC like Hickman or Broviac catheters, and implantable devices. Whereas CLABSI is defined as recovery of a pathogen from a blood culture. All right. Single blood culture for an organism not commonly present in skin, and two or more positive blood cultures for skin commensals. In a patient who had a central line at the time of infection or within 48 hours before development of infection with no other source of infection except the catheter, with evidence of microbial growth on the suspected catheter not being required. So this is used by the CDC. So it's mainly a surveillance definition used for public reporting and it is restricted to the application on patients with central lines. The problem is this definition can lead to overestimation of bloodstream infection incidents caused by the catheter infections, especially in ICU and hemato-oncological patients. So coming to the pathophysiology, so the commonest route is via the skin colonization. So microbes on the skin can migrate along the subcutaneous tract of an indwelling catheter and eventually reach and colonize the intravascular portion of the catheter. So the commonest commensals are staph aureus and coagulase negative staph. So deposition of biofilm on the external and internal surface of vascular catheter plays an important role in colonization. Then comes infusate contamination. So that is supposed to be the rarest cause. So suspected in an otherwise low risk patient receiving IV solutions with uncommon gram-negative bacteria. So administration of contaminated infusate or additives like blood products or contaminated heparin flush. Or the next route of contamination is through intraluminal contamination. So contamination of internal lumen of vascular catheters can occur through breakpoints in the infusion system, like catheter hubs, which is usually suspected in long-term indwelling catheters, especially dialysis catheters. And then hematogenous seeding. So microorganisms in circulating blood, especially due to infections of the GI tract, can attach to the intravascular portion of the indwelling catheter. So recurrent bacteremia from the catheter may be difficult to distinguish from worsening of the primary focus of infection. So the difference between these two can be identified by removal of the catheter, which may help in distinguishing these possibilities, either recurrent bacteremia from the catheter or a GA source. So coming to the microbiology, the commonest organisms that are usually isolated are coagulase negative staph, Staph aureus, Enterococcus, Candida, Klebsiella, E. coli, Enterobacter, and Pseudomonas. So in special populations, in burns patients, the commonest is Pseudomonas. In hematological patients, it is gram-negative bacilli. So the association may be due to translocation of gut bacteria in patients with an altered gut mucosal barrier. In hemodialysis patients, gram-positive bacteria, and in infusate contamination. Especially IV fluids, commonest is gram-negative bacteria, and in TPN, it is candidemia due to Candida parasilosis. So the risk factors, you can classify it into host factors and catheter factors. Host factors are those like chronic illnesses, bone marrow transplantation, immune deficiency, especially neutropenia, malnutrition, TPN administration, previous bloodstream infections, extremes of age, loss of skin integrity, like in burns. Catheter factors are duration of catheterization. The more the duration, the more the risk. The type of catheter material, the condition of insertion, whether it was done on an emergency basis or an elective basis, catheter site care, skill of the catheter inserter, the site of insertion. the highest being for the femoral root, submaximal barrier precautions, and multiple lumen versus a single lumen, with the multiple lumen having a higher risk. So in these risk factors, I've mentioned a handful of them. At least 3 to 4 should be in your mind when you, if at all you're asked this question. So the clinical manifestations. So the general presentation, they present with fever or inflammation, pain, or purulence at the catheter site, which can be associated with hemodynamic instability or an altered mental status. So if clinical signs of sepsis are there that start abruptly after catheter infusion, then a high suspicion of infusate contamination should be kept in mind. It should be confirmed with concordant growth of pathogen from the infusate and cultures of percutaneously obtained blood. Alright, so this is one thing that you need to keep in mind. We don't routinely look into this, but this also should always be at the back of your mind. So the lab tests, we usually do total WBC counts, CRP, procalcitonin. All these are non-specific, and blood cultures. So features of complicated catheter infection: hemodynamic instability, neutropenia, immunosuppression, and local exit site signs like cellulitis, redness, and purulent discharge. These four need to be kept in mind. Already, hemodynamic instability, neutropenia, immunosuppression, local exit site signs. So coming to the diagnosis, so we go by the 15-3-2 rule. Alright, so this is mainly when I prepared notes, this was something that I had written just to keep it as a good memory. So the diagnosis of CRBSI should be suspected in patients with fever, chills, and/or hypertension in the setting of a catheter placed for at least 48 hours prior to the development of symptoms. So the culture methods are: one, semi-quantitative culture of the catheter tip. So the distal 5 centimeters of the catheter is severed, and this is considered as a gold standard. So the same organism on the catheter tip and in the peripheral blood of about 10 ml is usually seen, and the growth from the catheter tip should have more than 15 colony forming units in 24 hours. That's why the 15 number comes here. The problem is it detects only the outer surface of the catheter, not the inner surface, which is a potential source of colonization from the catheter hub. Then we have the differential quantitative blood cultures, which has a diagnostic accuracy of 94%. So the same organism in the peripheral blood and the catheter blood is seen, and the colony count from the catheter blood is 3 or more times greater than the colony count from the peripheral blood. The problem is it does not detect organisms on the outer surface of the catheters. So that is the problem with this modality of testing. Then the last one, which most of us are very familiar, is the differential time to positivity. Even though it is something that most of us know, compared to the three of them, this is supposed to have the least diagnostic accuracy actually. So the same organism in the peripheral blood and the catheter blood is noted, and the onset of growth in the catheter blood is at least 2 hours before the onset of growth in the peripheral blood. So 2 hours is the minimum time difference that needs to be there between the catheter and the peripheral blood. So 15, 3 and 2. 15 for the growth from the catheter tip having more than 15 colony forming units. 3 for the colony count from the catheter blood being 3 or more times greater than the colony count from the peripheral blood, and 2 being the onset of growth in the catheter blood being at least 2 hours before the onset of growth in the peripheral blood. All right. So the two important differentials you need to keep in mind is primary vascular graft infection in those who have it done, especially like AV fistulas for hemodialysis, or any kind of grafting that has been done for any vascular abnormalities or vascular diseases, and mycotic aneurysms. That is infections of arterial wall causing development of new aneurysm, or when pre-existing aneurysm becomes infected in the setting of bacteremia. So coming to the treatment, we have two areas to keep in mind. One is catheter management, and other one is the antimicrobial therapy. So with regard to the catheter management, the first thing is you check if there is suspicion of a catheter related infection. If it is yes, Then you assess for whether there is signs of severe disease, that is shock, neutropenia, immunosuppression, local exit signs like purulent discharge, redness more than 5 centimeters diameter, and patients with prosthetic valves or an indwelling pacemaker wires. If any of these are there, then you need to remove the catheter. If not, you can go ahead with a watchful strategy, especially in patients with the long-term indwelling catheters. So many a times there may be patients with the long-term catheter, and for catheter salvage, you can go ahead with antibiotic lock therapy. So the same antibiotic used systemically in a concentration of 2 to 5 milligrams per ml in heparinase saline is injected and allowed to dwell for 24 hours. So during the 24 hours, the catheter should not be manipulated or there should not be any touching of that catheter during that period. So after 72 hours, you reevaluate again and reassess. So once you get the cultures, if it is a confirmed CRBSI, you need to assess if it is complicated or uncomplicated. If it is complicated, you need to remove the catheter and look for complications. Whereas if it is uncomplicated, you just go with catheter removal. Whereas after 72 hours, if you find that the cultures are all negative, or possible blood cultures are not related to the catheter, then you go ahead with the watchful waiting strategy. All right. Then coming to the antimicrobial therapy, if there is a suspicion of a catheter-related infection and there is a clinical and lab signs of risk factors for complicated catheter infections, then you go with empirical treatment. So for gram-positive coverage, either MRSA and enterococci, vancomycin is the first-line drug. If ICU is prevalent with MRSA that have vancomycin MAC more than 2 mics per ml, then you need to go with daptomycin. For gram-negative coverage, it is based on the local antimicrobial susceptibility and severity of disease. So based on your ICU antibiogram, you can go with either piperacillin tazobactam, cefepime if pseudomonas prevalence is high, carbapenem, and aminoglycoside if MDR prevalence is very, very high. So empirical antifungals are recommended in the following settings, like patients with a femoral catheter, TPN, hematological malignancy, prolonged antibiotic use, recent transplant. So the recommended antifungal is to go with echinocandins. So fluconazole can be used in the following settings. That is, there is no prior azole exposure in the last 3 months. In the healthcare setting where the incidence of Candida krusei or glabrata is low. So in these two scenarios, fluconazole can be attempted. So the complications following CRBSA, one is septic thrombophlebitis. So venous thrombosis associated with inflammation in the setting of bacteremia. It needs to be suspected in patients with CRBSA with persistent bacteremia after 72 hours of appropriate treatment. So the diagnosis is through duplex ultrasound and positive blood cultures, and treatment is antibiotics and anticoagulation if complicated, plus or minus surgery if it is persistent despite the above measures. Then infective endocarditis, where there can be infection of one or more heart valves, suspected in patients with CRBSA or bacteremia for more than 48 to 72 hours with pathogen associated with IE. And the most concerning one is the metastatic musculoskeletal infections manifesting as septic arthritis, osteomyelitis, or orthopedic hardware infections. So it is suspected in the setting of new onset musculoskeletal pain, but many a times in patients who develop new onset fever or in the ICU and has a catheter related infection, it is very, very important to look for these three complications. Because even after you remove the catheter, there may be times when the patient still persists to have fevers. And if it is not identified at the right time, then complications may ensue and it may further increase morbidity and mortality. So treatment of specific pathogens, if it is MSSA, you go with nafcillin or oxacillin, and the alternative is cefazolin and vancomycin. Whereas if it is MRSA, then you need to go with vancomycin, and the alternative is either to go with daptomycin or linezolid. So for enterococcus, if it is ampicillin sensitive, you go with ampicillin. The alternative is vancomycin. If it is ampicillin resistant but vancomycin sensitive, then you go with vancomycin, and the alternative is daptomycin or linezolid. Whereas if it is ampicillin and vancomycin resistant, then you will have to go with either daptomycin or linezolid. But the alternative would be quinupristin or dalfopristin combination, which is not usually effective against Enterococcus fecalis. For gram-negative bacteria, usually it is based on the antibiograms. So for Acinetobacter, the preferred one is carbapenems, provided there is no evidence of crab. Alternative is ampicillin sulbactam, but now the recent guidelines for crab infections is to go with Dodlobactam sulbactam. So that needs to be kept in mind. For E. coli Klebsiella, again, you need to know if it is carbapenem sensitive. If it is a CRE, that is a CRE bug, then you need to know whether it is a KPC, NDM, or a OXA. So based on that, you need to know whether you need to go with plain ceftazidime avibactam or you need to combine it with aztreonam. For Enterobacter, they are AMC producers, so the preferred agents is carbapenems. The alternative that can be used is cefepime. And for Pseudomonas, piptaz, cefepime, carbapenem, or aminoglycoside can be used. And piptaz, cefepime, or carbapenem should be used, and it needs to be done in combination with aminoglycoside, like amikacin. So for candidal infections, the ideal one is to go with echinocandins. So caspofungin, loading dose of 70 milligrams and a maintenance of 50 milligrams per day. And anrilofungin, loading of 200 followed by a maintenance of 100 milligrams per day. So the alternative, if at all these are resistant, then you need to go with liposomal amphotericin B. Fluconazole, if at all your cultures turns to positive for Candida and it is susceptible, then you can shift over to an azole. Or, like I said, in the two scenarios where the azole therapy can be used is if there is no prior exposure in the last 3 months, or your ICU does not have prevalence for Candida krusei or glabrata. So the duration of treatment is usually for 10 to 14 days, and for candidemia, it needs to be continued for 14 days after the first negative blood culture. So CVC checklist bundle, hand aging, good compliance is a must. Use of maximum barrier precautions during insertion, including fluid drape. Use of 0.5, preferably 2% chlorhexidine skin preparation for disinfecting and cleaning skin before insertion. Catheter site selection, avoiding femoral route and use of ultrasound guidance to decrease the number of pricks. Daily inspection of the catheter site, immediate change of unstuck, soiled or moistened catheter dressing, and removal of the catheter as soon as it no longer needed. So other important practice is scrub
Hi, Ajit.
the hub with isopropyl alcohol.